Hello, I'm Jean-Daniel Chiche. I'm pleased to attend this symposium and discuss with you how to assess lung recruitability in patients with COVID-19 infection. In the absence of a specific treatment, what we've learned regarding the treatment of COVID-19 infection is that basically we really have to focus on safe and lung protective mechanical ventilation strategies. And obviously, there's little discussion about the fact that we have to limit tidal volume and plateau pressure. However, with the description of different patient phenotypes, there's been more discussion related to the fact that some patients may actually benefit from higher PEEP with high recruitability, whereas high PEEP levels may be harmful in some patients that have a low proportion of recruitable lung. And in this very nice review article, Edifan and collaborators have proposed to individualize PEEP and consider higher PEEP only in patients that have a higher potential for lung recruitment. This is very much in line, I would say, with the recommendation proposed by the expert consensus conference from the SALF, where indeed in patients with the most severe hypoxemia and PF ratio lower than 200, they propose to use higher PEEP level and titrate PEEP if it does actually improve oxygenation. Interestingly, in patients with COVID-19 pneumonia, as Luciano Gattinoni has shown, you may have actually different respiratory phenotypes. If you look at these two patients, they have roughly the same PO2 FiO2 ratio. A patient depicted with a CT scanner in A is breathing spontaneously, and these patients have a very low elastance, low shunt fraction, low lung recruitability, and low lung weight. With roughly the same PO2 FiO2 ratio, the patient depicted in picture B, and this patient is actually ventilated with a PEEP of 5, has a very low compliance, higher right to left shunt ratio, with high lung weight and high lung recruitability. And we may wonder whether we could use the CT scan to actually titrate PEEP in these patients. This is more or less what has been proposed by Jean-Michel Constantin and his colleagues in this single blind randomized controlled trial, the LIVE study, where they propose to use lower PEEP and sometimes even higher tidal volume in patients that have focal lung morphology and maybe better compliance. As you probably remember, this study ended up by being negative in the overall analysis. But looking at a subgroup analysis, taking into account the fact that the patients were correctly or incorrectly classified as compared to their CT scan findings, they could see a benefit of such strategies. And this actually points out the fact that the CT scan may sometimes be misleading, and this is also true in patients with COVID-19 infection. Just to give you more clue to this very interesting letter coming from Marcus Schulz groups in the Netherlands has clearly shown that some patients have this H phenotype and indeed very low compliance, totally consistent with the CT scan findings. Whereas some patients, some of these patients will still have low compliance and rather focal lung lesions on the CT scan, and they are called to have discordant CT scan phenotypes. And the same is true when we consider patients with the L phenotypes, where indeed there's not a perfect correlation between the compliance and the CT scan findings. This actually points out to the fact that we really need to have tools to perform a bedside assessment of the potential for lung recruitment. And we've known for a very long time in ARDS patients that this potential for lung recruitment is extremely variable from one patient to another. Obviously, you will find a greater amount of potential recruitable lung in patients with ARDS as compared to patients with acute lung injury. But you can see that it's extremely variable from patient to patient, and that there's a nice correlation between the percentage of potentially recruitable lung and the lung recruitment measured between peak values of 5 and 15 centimeter of water. That was the most important conclusion of this paper published almost 15 years ago. So if we step back for a minute, can we identify patient and the potential for recruitment based on the Berlin severity? Can we look at patients with mild, moderate, and severe RDS and learn something regarding their potential for lung recruitment? The answer in one sentence is yes, if you assess this with a PEEP of 5 centimeter of water. And this is what has been shown in this very nice study from Pietro Chironi, where they've looked at patients with a PEEP of 5 and did correlate the potential for lung recruitment and the severity as assessed by the Berlin definition with a PEEP of 5. And you can see that the patient with mild ARDS with a PEEP of 5 have a lower amount of potentially recruitable lung as compared to the patient with moderate or severe ARDS. So this is really something very simple that you can do at the bedside to assess the potential for lung recruitment, including in patients with COVID-19 ARDS. Then you can move to something much more sophisticated and look at monitoring respiratory parameters. And we'll discuss in the remaining part of this presentation respiratory mechanics, FRC measurement, and gas exchange. We've known for a long time that we can perform low flow inflation PV curves. And if you start by doing a low flow inflation PV curve with ZIP, you will obtain this. And then you can repeat the measurement with a PEEP, for instance, at 10. Then you need to really assess how much lung remains in the lung, how much air remains in the lung with a PEEP of 10. And you do this by performing a long expiration to ZIP. The difference between the expired volume and the tidal volume represent the increase in an expiratory lung volume induced by PEEP. This has been nicely delineated by Johnson and colleagues 20 years ago. Now, what you can do as soon as you have this measured this increase in an expiratory lung volume increase by PEEP, you can superimpose these two PV curves and assess the recruited volume. This is cumbersome, and some people have proposed to use a different and alternative method, which rely on your ability to measure functional residual capacity at the bedside and expiratory lung volume using the nitrogen washout washing technique, whereby changing the FiO2 by roughly 10%, you will be able to measure after a couple of breaths, if your patient is metabolically stable, you will be able to measure the changes in FRC. And when you take into account the difference in N expiratory lung volume and also the minimal expected increase in lung volume that can be computed as the difference between the two PEEP levels multiplied by the compliance at the lowest PEEP level, you can then have an estimation of the recruited volume. In this study, De La Monica and colleagues have compared these two methods, the low flow inflation PV curves and the measurement in N expiratory lung volume, and you can see that there is quite a nice correlation between the two methods to estimate alveolar recruitment. And this can be used to separate the patients that have higher potential for lung recruitment. You can actually measure lung recruitment using these FRC methods. There's a third method that can be used that has been quite recently described, and it's really interesting to look at this paper published in 2018 in the Blue Journal. In this paper, the Toronto group have described a phenomenon that was unknown until then, that is an airway closure phenomenon. What you can see here, for instance, in the three PV curves, low flow inflation PV curves, obtaining the same patient in the inset A, B, and C, with a ZIP condition, a PEEP of 8, and a PEEP of 18. You can see that in ZIP, there's virtually no inflation of the lung. That's totally superimposed with the compliance of the respiratory, the closed respiratory circuits, until you reach a PEEP of 15. If you start your PV curve with a PEEP of 8, you still have the same airway closing phenomenon until you reach this PEEP of 15. And this phenomenon disappears when you perform an inflation PV curve starting from a PEEP of 18. In patient D, you can see that even in deep condition, you do not see this airway closure phenomenon. The consequences can be really important because the measurement of the airway pressure at end expiration can be totally misleading in the presence of this airway closure phenomenon. Then the risk of ventilator-induced lung injury also can be underestimated if you set the PEEP under the airway opening pressure. And you also run the risk of having the development of denitrogenation atelectasis if some of the zones are unintermittently reopened. In this study, overall, it was the PEEP level was 13. Doing so, you can actually define a PEEP level, the compliance of the recruited lung, and that's quite helpful to actually measure what has been defined as the recruitment to inflation ratio. This recruitment to inflation ratio is quite easy to measure, and it can be defined as the difference between the compliance of the recruited lung and the compliance that is present either at the PEEP level or at the airway opening level. The higher the recruitment to inflation ratio, the higher the potential for lung recruitment. And in this very nice and quite interesting study, what has been shown is that in the absence of airway closure, you have a nice correlation between this recruitment to inflation ratio and the PF ratio, as well as with the alveolar dead space. And in patients that have high recruiters, these patients have a recruitment to inflation ratio greater than 0.5. Overall, this could be one of the techniques that is available at the bedside to actually define who benefits from lung recruitment at the bedside. So in summary, we could say that most COVID-19 ARDS patients can be managed safely with lung protective ventilation, that assessment of lung recruitability at the bedside is now feasible and paramount, and that this could be helpful to know which COVID-19 patient could benefit from IPEEP or not. Thank you for your attention.